Hi, I'm Dr. Sunny Hatch, scholar in the John P. McGovern Academy of Oslerian Medicine. Our usual format for discussion is altered by the current COVID pandemic, requiring social distancing to minimize transmission of the disease. Ironically, our topic today is entitled Care Carefully and is found in Chapter 6 in the book by Dr. Charles Bryan, entitled Osler Inspirations from a Great Physician. Through our discussion today, we will hope to address the question of, are physicians obligated to be caring, concerned, and compassionate? I'm with Jessica Stauber today, who is a student scholar in the Academy and has chosen a career in radiation oncology. She's a passionate patient advocate and is very involved in the Global Health Initiative. Before we get started, I'd like to read to you two of Dr. Osler's well-known statements regarding caring. The first is, the motto of each of you as you undertake the examination of a case should be to put yourself in his place. Realize, so far as you can, the mental state of the patient. Enter into his feelings. Scan gently his faults, the kindly word, the cheerful greeting, the sympathetic look. The second statement is, it is a hard matter and really not necessary to tell a patient he is beyond all hope. Which gets us to, what is caring? And Jessica, I understand there's a whole vocabulary when it comes to caring. Maybe you could tell us about that.
Yes, ma'am. So, like you said, there's a wide vocabulary when it comes to caring, and so I think there's not really one definition for caring itself that we can, fall back on. So, one component that we are frequently talking about as medical students these days is beneficence, and that is active kindness. So, actively showing that you care for the patient through what you're doing and how you're treating them. Then there's empathy, which is simply a matter of just understanding the patient's feelings. So even if you necessarily or haven't necessarily had something like that happen in your life, you can still understand where they're coming from. And sympathy requires that we not only understand, but also experience feelings similar to the patient's. So we are actively feeling with the patient rather than simply understanding. And then compassion goes a step further, and it requires that when the patient's suffering, we are also suffering and we're also feeling that distress. And so I think this kind of breaks down caring into different levels and how we approach our interpersonal relationships and interactions. An example is you can't quite compare one patient's situation to another. So if you have a patient that maybe has a more favorable prognosis or what we would consider a mild illness or disease versus somebody who's maybe on end-of-life care, we can't treat a patient suffering who might be better off as invalidated or maybe as needing less care than patients who have a more serious prognosis. So in caring for patients, I try to take an approach of who is this patient, what do they value, and what are they feeling and why? And I don't take into consideration, well, this patient is worse off or this patient's better off. So I don't necessarily put, not sure what the word I'm looking for is, but I guess requirements for needing my care or requirements for needing a certain level of care, if that makes any sense.
It does, and those terms do get kind of muddled up, don't they?
Mm-hmm.
I imagine when, what probably our audience doesn't know is that prior to going to medical school, you were actually a nurse in the NICU, is that right?
I was, yes, ma'am.
And so I imagine there was plenty of opportunity to have some introspection regarding caring along those lines.
Absolutely.
Touch is very important, and that topic was hit upon in this chapter. And you once shared with me something that had occurred within the NICU as far as encouraging touch for that infant. Could you tell us about that?
Yes. So actually, well, as is well established, and as we tell parents who have babies in the NICU, and even new parents whose babies are not going to the NICU, who are born healthy and full term, the skin to skin, that physical touch that we give babies is very beneficial. It's not just, it goes beyond bonding, though that is certainly one of, a very important factor in the skin to skin and physical touch, but their respirations improve, their heart rate is stabilized, their temperature regulation is much better when they're skin to skin, their stress levels go down. Babies who are on oxygen support and premature babies have improved oxygen saturation when they're with skin to skin, and this is backed by the evidence. It's not just something that we see. I mean, it's certainly something I've witnessed, but again, it is very well backed by the literature. And so that being said, something that makes this process very difficult, especially for our teeny tiny micropreemies, is all of the connections. So they may be intubated, or they're very likely on some sort of respiratory support. And on top of that, they also have wires monitoring their heart rate, their oxygen saturations, how fast they're breathing. And a lot of them have lines, multiple lines, so IVs and different central lines and arterial, just a lot of junk that they're attached to, these teeny tiny little babies. And so for parents who are already very stressed about holding such a fragile little baby, having to kind of maneuver through all the different lines and attachments as we're taking the baby and placing them on the mom's chest or the dad's chest can make things very stressful and difficult. And even for the baby, that transition time until they get settled on mom can involve some stress. But early last year, a group from Northwestern University in Illinois developed this sensor that was shown by some of their trials to be highly accurate and sensitive in measuring, or precise, for better words, in measuring a baby's heart rate and oxygen saturations, and many of those vital signs that require multiple cords and wires. And this sensor is not only wireless, but it's much kinder to the baby's skin, which is already very fragile when they're born prematurely. And it significantly improves the skin to skin experience, and it makes it easier. Again, it's better for the baby's skin, and it just it gets rid of a huge barrier to that skin to skin time.
I guess the mother is less apprehensive to hold the child as well, which would encourage bonding. Is that right?
Absolutely. Encourage bonding, as well as there's suggestions that some evidence has shown that hospital stays may even be decreased by frequent skin to skin with the mother, and a lot of physiologic benefits as well. They're truly endless.
So during all this time, both as a nurse, but also as a medical student in your involvement in patient advocacy and global health, you became ethnocentric. You began to develop a conscious awareness, if you will, of the differences between cultures and how cultures interact not only with each other, their expectations of what a patient is, but also the expectation of that doctor-patient relationship. Could you elaborate about that a little bit?
Absolutely. I think kind of going back to what I was saying about giving individualized care to others and expressing that in a very unique and individualized manner, that certainly encompasses cultural sensitivity. Somebody's cultural background and cultural preferences, or the cultures that they're born into, affects not only the patient-physician relationship or interpersonal relationships, but their family values, their values on the birth experience, for NICU in particular. and even their values regarding end-of-life care and bereavement. And these are all very important things to consider when you are dealing with patients, because you don't want to do something within your culture that's, considered valued and appropriate in your culture, and then in turn disrespect their culture. A specific example that I had during my time as a nurse, I was the primary nurse for a Chinese baby that was born at 24 weeks. So I was his primary nurse, so every day I worked, he was my patient all the way through discharge. And his parents had come here from China a few months ago, and one of the Chinese culture, or a part of the Chinese culture, is after they deliver a baby, the mother enters into a month of confinement, to where she has bed rest, strict bed rest. There's only a certain types of foods she can eat, even the liquids that she drinks, very, very strict. And the purpose of it is to restore balance to the mother's body after giving birth to this baby. And for somebody whose baby was in the NICU, this was very difficult because she was separated from her baby. And so she stayed in her confinement for a month. And so for the first month of his life, she was not able to be there. And for me, from an outsider's perspective, you think, well, how are we gonna, maneuver that first skin to skin contact and the touch and all this stuff? And so I worked with the baby's father to facilitate, like, video calls, for example, is what we did, and she would speak softly to him, so that he could hear her voice, and just little ways that we could help her feel connected to her baby while she was going through this month of confinement. And even after that, in the Chinese culture, a big celebration for a baby is the 100th day of life. It's the equivalent, if not more important to them than a baby's first birthday here in a Western culture. So they often have a very big celebration. People bring gifts in the form of little red envelopes for the baby. And it's a very important day because they believe that if a baby has lived for 3 months of his life, then it's a sign of a very good life. And for my patient in particular, he was still on the NICU during this day, during his 100th day of life. And so even though they couldn't quite have the giant family gathering with their family and friends that they were expecting, we still had a NICU-friendly celebration for him within the unit, involving his nurses who had taken care of him, as well as his parents, his mother and father. So we really, knowing these cultural values, just really enabled us to go a step beyond just, a standard of care.
So usually we think about it just as language barrier, and that is bad enough, right? Especially in these days when we're wearing masks and we're trying to use an interpreter to explain what we're trying to say in respect to the person and to their health. But in some cultures, the family likes to be told first, and then they make the decision about what the patient is informed. And I know your younger patients, that certainly wasn't an issue. But have you come across that at all?
I personally have not, but I've had a lot of discussions in my practice of medicine courses, as well as some of my ethics and humanity courses in medical school, about what would we do if we came upon that. And I think it is a very difficult situation to maneuver through, because we're taught, obviously, that the patient is first, and so the patient gets priority, and being told their diagnosis and prognosis, and them being the ones that determine care from there. And I think through just discussing this with multiple different professionals and trainees in the field, in cultures such as that really do value the family decision making, certainly just still involve the patient. So I think there's still a way to prioritize family decision making while still involving the patient. So, for example, discuss with the patient, what would you like? Would you like to be told first about whether it's a diagnosis or a prognosis, or a treatment plan, or would you rather us approach your family? And so I think that kind of is a good middle ground to come to where you are still respecting patient autonomy and respecting their decision making as far as their care and communications go, while also respecting their cultural preferences by opening the door for them to communicate if that is what they prefer for their family to be kind of the first source of contact.
So I guess the first step is just being culturally aware, is that right?
Absolutely.
The practice of medicine is an evolution, but the doctor-patient relationship is a constant. Each patient, no matter their race, sex, age, or economic status, needs to know and feel that we are there for them.
UTMB Health, working together to work wonders.